Good morning, everyone, and thank you for joining us today for our Rush University Medical Center Children's Hospital Town Hall meeting with RettSyndrome.org and the Rett Syndrome Association of Illinois. I'm so glad to have you with us today. I would like to give a few brief housekeeping pointers on how GoToWebinar works for those of you who are joining us for the first time. Don't have to worry about any noise in your background. You're automatically muted and your webcams are off. So if you're on your couches, your porches, your kitchen table, go ahead and be comfortable, and don't worry, just sit back and listen and be comfortable. We are awfully sorry that we're having to do this virtually. We had hoped to be in person on this day and time when we planned our Ed Day together, and we will be sometime again soon, but this is the next best thing. So I hope that this enables actually more family members to join you and for you to more comfortably listen to all of the information while doing the things around your house that you normally have to do. The second thing is that this session is being recorded, so if you have to leave early or if you'd like to share the link to the recording with someone on your care team or other families in the area that weren't able to join us today, you'll get a link automatically to the recording within a day or two. Okay, if you look to the upper right corner of your screen, you'll see a control panel. And if that's in your way of the slides, go ahead and drag and drop it down to the bottom corner, and you can bring it back up if you'd like to type in any questions for our presenters today. We have a fantastic slate of presenters, and so I'm sure they're going to answer a lot of information that's been on your mind, but you can also type in questions that come up based on the presentation that they give to you. We also have received all of your wonderful questions that you submitted in advance, and we'll be addressing those at the end of our town hall, okay, at the end of the slides. So thank you for sending in some of your very thoughtful questions. If you're having any trouble hearing, try and check and turn up the volume on your phone or your device. If you're having any trouble at all, sometimes just closing out the app and logging back in takes care of the problem. If you continue to have technical problems, just write it into the chat, and Katie Bush or myself will try to help you out. Okay, so thank you. That's enough of the housekeeping here. All right, I want to give an acknowledgement to our sponsors who support RettSyndrome.org and make all of our educational programming possible throughout the year, which has been especially important to us in this difficult year when many fundraisers have had to be canceled, postponed, or taken virtually. So Acadia Pharmaceuticals, Greenwich Biosciences, and Neuron Pharmaceuticals, thank you so much for your support. Here's our agenda today. I'm here to do a quick welcome, and then we're going to hear from your experts at the Rett University Rett Center, which will include Dr. Peter Heydemann, Dr. Colleen Buhrfiend, and Dr. Lisbeth Kravis. Fantastic lineup. I'm going to bring some information to you from RettSyndrome.org, as well as Shelby Sawyer, who's your Rett Syndrome state rep. And then we're going to hear from the Rett Syndrome Association of Illinois. Paul Yoakum is going to represent the foundation. Now, really, we know the definition of a town hall is an opportunity to have a stage where we can bring you current information. So today is not a session to educate you about Rett syndrome or a specific symptom or a specific topic, but it's really to give you an update as to where we've been all summer and some things that have happened since our change of events. So we'll stick through this agenda. I'd like to share a quote with you before we get started. I think that for every one of us who as parents, whoops, sorry about that, my slides, okay. You know, and I have a child, a beautiful teenager with Rett syndrome. I know that there's no timeline that is equal for all of us in terms of when we come to terms with this diagnosis for our child, but this quote to me really resonated, and it's from a parent who said at the 2-year mark after diagnosis that today marks 2 years since we found out their daughter has Rett. And before she was diagnosed, I worried about why can't she do this? When we got the diagnosis, it was she won't be able to do this. And now I try to focus on figuring out how can she do this. And I'm so proud of her for all that she has and continues to accomplish. While I still have moments of sadness and worry about what the future will bring, I'm trying to ground myself in the present because it's a good place to be. And I think although the timeline might be different for everybody, especially for our families who are with us right now and maybe just received the diagnosis, or for families who are further on down the line, I really want you to take this information and take it to heart, because we all went through a similar journey of, for the most of us, bringing a child home from the hospital who had a clean bill of health. And then we started to see some things that she or he had stopped doing, and that sent us into a whole world of confusion and a journey to find out what was going on. Then when we got the diagnosis of Rett syndrome, we heard the scary words regression, and we didn't know what that meant. And we probably universally all sunk into a state of fear and worry that she wouldn't be able to do anything, that maybe our child would wake up tomorrow and not be the child who went to bed the night before. What I hope today is that what you'll find through the relationship with RettSyndrome.org, the Rett Syndrome Association of Illinois, and especially this beautiful clinic that has grown up in your own community at Rush University, that you're not alone, and that we can give you information to get you to that place more rapidly, more quickly, and during different times where you're focusing on what she can do and what the hope of research has really brought to us, to change our whole perspective on this journey that we share called Rett syndrome. So right now, especially, we find ourselves at the crossroads of so many issues that are grabbing our attention. We have global issues with the pandemic, societal issues. We have intense elections coming up. We have environmental issues with fires on the West Coast and storms in the South, and my heart goes out to everybody. I'm dialing in from California. I'm feeling that very personally. But this journey of Rett syndrome is very personal, and it really was consuming of our attention before all of these events. And I think one of the strengths that I'd like to remind you all is that we have some tools in our toolkit because of our journey with Rett syndrome that will help see us through what a lot of people are having to find within themselves now, which is that we know that there are some things that we can't control. We did not cause Rett syndrome in our children for the most part, but we are here to support them, and we do have it within us to make it through this journey. So today we want to recenter and refocus our attention on Rett syndrome. We know that Rett syndrome has no boundaries. It affects 1 in approximately 10,000 worldwide. Most have never heard of it. No parent wishes for it, but here we are. And what we know is that the bright and engaging eyes and smiles of our mostly nonverbal children do envelop our hearts and minds with purpose and move us to find strength that we never thought possible. All of us at Rush, RettSyndrome.org, Rett Syndrome Association of Illinois, are committed in partnership to offering connection, education, and advocacy for all affected by Rett syndrome while investing in advocating for research progress. I say that as your advocate at RettSyndrome.org and as a mother of a beautiful teenager with Rett syndrome. It's been our pleasure to co-host so many conferences in the Chicago area over the years. I love seeing all the names on here of people that I know who have become friends in my life, who have helped these conferences, events, natural history studies happen in the Chicago area, and have helped foster and grow a beautiful clinic right there in your city. Some of the best families who have been the most transformative to the energy and progress in Rett syndrome come from the Midwest, and specifically from Illinois. Many of you have started parent associations. You serve on the board for RettSyndrome.org. You have helped volunteer to mentor and carry along other families. You've held fundraisers, and all of those efforts have created a community in the Midwest that is strong, that's powerful, that overcomes each and every day, and sets a wonderful example for the rest of the world. So I thank the friends that I know who are with us today, and I welcome the new families that have yet to get to know everybody because we haven't had a chance to be in person, but I promise you we will be together again. So with deep gratitude, we especially thank our upcoming presenters from Rush. We know it has been an exhausting summer for you. We know that the way you practice medicine and conduct research has been turned on its head, and you haven't let us down. You've been with us nonstop. We know you're tired, but you remain committed, and we really thank you for being with us on this Saturday to give some updates about where you are and the continuity that has happened for the last few months and what you see on the bright horizon on our future. So thanks for giving me a few minutes to say good morning to you all. I'm going to go ahead and turn the screen over to Dr. Buhrfiend. No, I'm sorry, to Dr. Heydemann. Okay, I'm going to go ahead and invite Dr. Heydemann now to kick off our official town hall. Reminder that if you have any questions for our presenters, go ahead and type them into the question box. Okay, Dr. Heydemann, if you'd like to turn on your webcam.
Okay, I'm on, the best I can tell.
Great, thank you. We see your slides.
Unfortunately, I see me, so I've got to get rid of me.
If you, just
Oh,
click on your slide and that should bring it up.
Only me. Just a second. Why did that happen? I'm sorry.
No problem.
Screen is
We're accustomed in a virtual environment to have technical stuff happen. Your slide did come up just a minute ago, so.
Yeah, and then let's see, I'm going to X myself out, and there we go. I may never see myself again, but that's how it'll be. At any rate, Paige, that was a very poignant opening and a great story and a good discussion of the time. So thank you for that. And as usual, it's nice hearing you speak because you have a great way of putting Rett syndrome in perspective. I want to thank your organization, rettsyndrome.org, in particular, all the people who participated in meetings and planning this. We started off with a full day planned for a long meeting and lots of speakers, and we've narrowed it down because we know video attention spans aren't nearly as long as in-person attention spans. So we will we'll move forward with our hour-and-a-half or so presentation. Thanks to you, Paige. Thanks to Katie Bush. Shelby Sawyer will be participating today. Pardon me. And thanks to the Rett Syndrome of Illinois people, Marie Krall, who helped me initiate this clinic, well, at least the hosting the Rett Syndrome Natural History many years ago, John McGovern and Paul Yoakum, who helped participate and get this whole event going today. We are very proud to maintain the Rett Syndrome Center of Excellence in Chicago and to keep the Rett Clinic going through these difficult times. 3 pediatric neurologists will speak to you today, myself, Dr. Colleen Buhrfiend, who will speak next about the basics of our clinic and talk about COVID adaptations that both the hospitals and clinics and the patients have had to make. I will talk quickly about the research trials that are going on at Rush, and Dr. Barry Kravis will be our keynote speaker. She'll talk about the research in rare diseases, especially Fragile X, which has been her research focus over many years, but she's spread out broadly, and she'll talk about the exciting possibilities that we see in these diseases. So with that, let me hand the reins over to Colleen Buhrfiend, and go ahead, Colleen.
Okay, can you hear me? I'm gonna try to. All right, can everybody see my screen?
We sure can. Thank you, Dr. Buhrfiend. We can see you and your slides. Thanks. Sorry, I was on mute.
Oh, no, that's okay. All right. So welcome, everyone. As Dr. Heydemann said, I'm going to talk to you a little bit about our Rush Rett Clinic today. So what we have is a multidisciplinary clinic. And the good thing, or the terrific thing about a multidisciplinary clinic, it allows for you to bring your child into the clinic and see multiple subspecialists or specialists at one specific visit. So instead of making multiple appointments and going out at different times, you can come and see everybody at one time. So I think that that's really a very good strength of a multidisciplinary clinic. The other thing too, from a physician standpoint, it allows for us to be in close proximity to each other and to other specialists so that we can discuss if there's a specific problem with the patient. We're all there to kind of discuss that and then come up with recommendations and a plan kind of as a whole. We kind of think of that as a collective power of a group. So a multidisciplinary clinic is really, it's really great from both of those standpoints. It helps the patients, but it also helps us as physicians as well to provide better care. So in our Rett clinic, we see obviously we see Rett syndrome, but we also see the Rett related disorders. We see the CDKL5 patient disorders, we see the MACP2 duplication syndromes, we see patients with FOXG1, and we see both males as well females as well as males, and we see the kids from early infancy and will continue to follow them all the way through adulthood. So right now, our clinic, we're doing, because of COVID, we have two options. We still see, we see patients through video as well as in person. Now, with regard to the video visits, there are some drawbacks. So obviously there's nobody there to go ahead and get a weight. So we do have some difficulties getting weight. So we ask that if prior to doing a video visit, if there's any way that you can get the weight of your child prior to the visit, that would be terrific. One of the ways you could do that is to weigh yourself, then hold your child, get on the scale with your child, and then get off the scale and obviously do the math. And this will allow for us to get your child's weight, especially if your child can't get out and step on the scale themselves. The other thing that may be helpful is to kind of take off the patient's AFOs and other braces so we can more easily do the exam at that time. And just have some minimal clothing that will also kind of facilitate that the video visit. You might also have, if it's possible, it's not always possible, but you may have two people there, one that can hold the camera and the other one that can work with your child and help to change positions and just kind of assist with the exam portion of the visit. So two people, it would be nice if you could have two people there. The other thing to remember is if your child is having some sort of spell, whether it's seizure or Rett spells, maybe to take a video of that. And if there's a way that we could get that beforehand, that would be great. So that's something to consider. The other problem with video visits is obviously it's difficult. We're not able to get an EKG at that visit and we can't get labs. So that's also something to take into consideration. And that's also can be a problem with the video visit. But you can also go out to your a nearby pediatrician if they offer those services, or to a nearby hospital, community hospital for those. But those are just some of the drawbacks to the video visits. With regards to in-person visits, we're still doing those, and I want to assure everybody that it's very safe. This is a picture of our our waiting room here, and you can see that that the chairs are set 6 feet apart. Here's two sets of chairs, and here's another set of chairs. So all of the chairs are set 6 feet apart from each other to practice that social distancing aspect. Now there's only two family members. Both parents are now allowed in the clinic, but no siblings and no other relatives. So only 2 adults are allowed in the clinic at this time. Masks are to be worn by everybody in the clinic, and although we understand that some of the children are not able to wear the mask, so in that case it's all right, but otherwise masks are to be worn, and the areas are kept clean. We clean the waiting room several times throughout the day. Here's a picture of our clinic rooms. Again, the clinic rooms are also kept very clean. The examination tables and chairs are wiped with disinfectant wipes after every single visit. And we ask that the adults, and if the child's able to wear a mask, that they continue to wear the mask throughout the entire visit. They shouldn't take the mask off anyways, even while they're in the hospital. So this is just to show that it is safe and we are doing in-person visits. Appointments, if you're interested in scheduling appointments, Irma Davila is our contact coordinator. So you can call the number here, the clinic number is 312-942-3034. You go ahead and call and ask to speak to Irma and she'll schedule the appointments for you. So I'm gonna go through the physicians who see the patients in our Rett Clinic. So we have 2 pediatric neurologists. You've already spoke, Dr. Heydemann has already spoken, myself. We address issues such as epilepsy, Rett spells, abnormal movements, motor difficulties, drooling, sleep problems, and behavioral problems. We also have 2 pediatric gastroenterologists, Dr. Mahendra and Dr. Makani, where they will address problems with weight, growth and nutrition, difficulties with swallowing, gastroesophageal reflux disease, delayed gastric emptying, constipation, gallbladder problems, bloating, discomfort, and they will place gastrostomy tubes if they are needed. We also have Dr. Laura Dion she's a pediatric medicine, a rehabilitation specialist, where she addresses problems with muscular tone, including hypertonia, hypotonia, and rigidity. She may use treatments such as baclofen or Botox. She can also advise with regards to the needs for orthotics, braces, hand splints, elbow immobilizers. She can also make recommendations for standards, gait trainers, and we'll be able to refer you to the seating and positioning clinic, as well as make recommendations regarding appropriate therapy. So she's a great asset to our clinic. So Dr. Wen was the pediatric cardiologist who was working with us. He has since left for Texas, but Dr. Cindy Sosnowski has offered to take his place, so we're lucky for that. She will go ahead and continue take his place and continue to look for any sort of problems, especially with the prolonged QTC, which is common in Rett patients. So she'll go ahead and she'll often get an EKG, do some Holter monitoring if that's necessary, and an echocardiogram. She will also treat if your child is diagnosed with the QTC, prolonged QTC. Dr. Paola Suzanne is also works in our clinic as well. She's a family medicine doctor who specializes or has a significant interest in patients with disabilities. Here she can talk about just the general health of the patient, as well as women's health and menstrual suppression. So she's also available as well. And then we have Dr. Elizabeth Berry-Kravis, although she doesn't see patients in the Rett Clinic. She is kind of the director of the research in rare diseases at Rush, and has her hands in all of the clinical research that goes on at Rush. So we're very happy and lucky to have her as part of the group. So new times, COVID times, you can see here. Here's a little boy and his teddy bear wearing a mask. And so there's been a lot of questions regarding this and what to do. We do definitely recommend masks, but we also realize that many girls cannot wear them. This could be due to like drooling or biting, or they may have the hand, mouth, face stereotypies, or they may not feel, they have like problems, they just don't like the mask on their face and sensory hypersensitivity, and they become very irritable. And in these cases, it's just a mask is not, it's not gonna, they're just not gonna be able to wear a mask in these cases. So we can talk about some other alternatives for masks, and I'm gonna do that on the next slide. So kind of hold that thought, but I wanna continue with what I have on this slide for a second. It's also important during this time to make sure that the girls all get their regular vaccinations, including the flu vaccine, and you should probably get that flu vaccine as soon as possible. We've also had a lot of questions regarding whether the child should remain virtual, learning through the computer versus going into school. And, you know, it's a really hard question to answer, but I think the best way to answer that is that you have to take the individual child's needs into play. So if a child is able to pay attention, some kids are able to pay attention and they are actually getting and learning through the computer. So if that's the case for your child, then I think that computer learning virtually is fine. However, there's some kids that are not able to look at the computer for more than a few minutes, and they would do much better in the classroom where they're exposed to multiple modalities of learning, where they can have teachers and aides to encourage them. And in this situation, the kids would be better off in the classroom most likely. The other thing to consider too are the needs of the family. There are some families where the parents have to they have to work, whether they're going outside of the house to work or they're working at home. It's very difficult to have to help teach your child and work at the same time. And so in that situation, you may need, it's better for that child to go to school. There also may be some distractions in the house where you have younger children. And so in those situations also, it's important maybe that the child instead go to school instead of learn through the computer virtually. So taking into consideration both the needs of the child or how well the child does as well with virtual learning as well as family needs is important. And so it's more of an individual decision. The video therapies, the same thing holds true for video therapies. We do think that it's important for the children to continue to make progress. So if you see that virtually your child is becoming more, having like increased tone or becoming more spastic, or if their mobility, they're not as mobile, or they're not interacting as well, in those situations, in-person therapy may be better for the child. But if they're doing well and the parents are able to help and become almost like a therapist, right, where they are providing the therapy, then that works out great. That would work out great for that family. So again, it's an individual. You have to decide individually what's best for your child and for your family. Solutions in the classroom, we talked about wearing a mask. So definitely masks are really important if the child can tolerate them. If they're not, if they cannot tolerate the mask, we've talked about you can use a face shield. They have the face shields with like the little hat, which a lot of the girls may tolerate this over a mask. Then there's these rain shields. They're plastic, large pieces of plastic that go over the wheelchair or their stroller. So that's something to consider, especially in transport when the child's maybe getting off the bus and going into the school, going through traveling through the hallways. You may want to use this plastic rain shield to protect them. And then of course there's the social distancing in the classroom. Hopefully there's not a large number of students in the classroom with the girls or boys. The teachers, aides, therapists, the teachers, aides, the aides, and the therapists must wear masks at all times, and I'm sure that they're doing that. You can ask about gloves. I mean, gloves may be important during times of changing and feeding, and if they're wiping their noses and so forth. And they should always, if they're wearing gloves, change their gloves when they go from one student to the next. And if they're not wearing gloves at all times, that they need to wash their hands frequently, especially if they're carrying from one child to the next. So they need to wash their hands or use hand sanitizers. Plexiglass is being used in some offices. Something to consider, I don't know if they're implementing or using this necessarily in between the desks in the classroom, but that's something to ask about. The other thing that you want to think about is like there may be new staff with COVID. There's been a large turnover of staff, and so you want to make sure that the staff, especially if there's a new teacher or a new aide, that they know your daughter or your son. So they need to know whether or not they should be aware of what their seizures look like, what their Rett spells look like, make sure that they know their baseline. For example, if they cough on their secretions from time to time, or if they cough a little bit during feedings, this is something you should let the staff know this, because otherwise they may think of this as a COVID symptom and send the child out. So it's important for them to know your child's baseline. You may want to do a video so that can help show exactly, what's a seizure versus maybe what's a Rett spell. And then with regards to the bus, there's oftentimes a lot of helpers getting the child off the bus. So you may ask the school how they've changed that, see if they can, minimize the number of people helping the children get off the bus to minimize contact. So those are the kind of the solutions that we have thought of. So, and I think that ends my slide presentation. Okay.
Thanks, Dr. Buhrfiend. That was really wonderful. We know all of these things are very personal decisions, and we can better anticipate our risk level being informed. And so making the decisions about whether to go back to school, whether to come into clinic, whether to continue doing things from home you just shared a lot of really helpful information to help parents make decisions. And I know you're available if anyone wants to talk through their individual concerns and anxieties, but we have to live in this new norm. So thank you very much. Those are big questions on everybody's mind. Dr. Heydemann, let's have you take the screen back. We see your slides and we look forward to hearing more information about clinical trials. Thank you.
Okay, thank you, Colleen. Well, clinical trials have been increasingly prevalent over the last few years. And, one of the pieces of evidence about that is what's new at rettsyndrome.org. They've just over the summer put up web sections about Rett Research Ready and My Rett Trial Finder, both of which are things that can help you find a clinical trial if you feel that's something you want to delve into. Clinicaltrials.gov is the government website, which has been available for many years, which covers all the disorders for which clinical trials are done. But it's very easy to search it with the right terms. You just put Rett up there, and you'll get the trials that relate to Rett. So those are ways to search for clinical trials. Currently, we've been involved in a lot of clinical trials recently. There are some open, some closed, and some ended. Rett syndrome natural history study, the Trophenite trial, the Ketamine trial, and the CBD trial are ones that are currently open and registering patients. The closed trials, which actually still have people in them and ongoing, are ganaxolone for CDKL5, the Anavex trial, and Dr. Wen's long QT syndrome protocol at Rush. And the ended trial is Sarazotin. Now, families may wonder what's useful about joining a clinical trial. Why should you? Well, the treatment might just be effective. You might be at the early end of treatment in something that really helps Rett syndrome, and your child will gain directly from it. And those early years where you think benefit can be obtained will be useful. At the same time, all these trials help to advance the care of Rett syndrome and the knowledge base of Rett syndrome. So we're doing something that will help everybody. There are reasons why people don't join clinical trials. One, there's a time commitment. There's travel, you have other kids and other things to do, and jobs and time off, and those are all things to deal with. Then there could be a side effect. After all, many of these medications are not FDA-approved medications, although some are. And some are approved for other purposes, but not the one we're talking about. Cost worries generally should not be a concern because organizations and the companies who sponsored this generally cover the costs, like hotel bills, travel fees, and so on. And then there's the current issues, the COVID issues. As Dr. Buhrfiend explained, in the clinic, the rooms are cleaned between patients. The hospital takes your temperature walking in. We try to limit the number of people who come with the patient into the medical center. And so we minimize these COVID exposures. And furthermore, the organizations that do the studies, the drug companies, for example, have agreed to do many of the visits outside the medical centers. We used to do everything inside the medical center at the home base, but now it's been arranged to do some video visits, to do some laboratory work outside the medical center at home localities or in local labs, so that the amount of travel and time commitment may be less given the current adaptations of our studies. The Rett Natural History Study, I should actually call it the Rett and Related Disorders Natural History Study, has been a key to our gathering objective data about Rett since 2002. Initially, we had the traveling clinic, for which I'm very grateful to get my start in Rett, where we hosted as many as 75 girls per weekend, or 75 subjects per weekend. And we got a lot of experience seeing Rett girls since then. And I shouldn't say Rett girls because this includes boys, boys with MECP2, MECP2 duplication syndrome, FOXG1, CDKL5, and Rett syndrome without a visible mutation. The natural history study includes all age groups. It starts with infancy, when there are yearly visits, and the timing of visits is spread out much wider as kids get older and into adulthood. It's a non-invasive trial. There's no blood tests, questionnaires are done, physical exam, outside data is looked at, like electrocardiograms and growth charts and gene tests. And this really has been an important background study to help advance all the drug studies that are being done, because it provides us with a much more objective knowledge base. So we invite everybody to join in this study. And we can now do this with video visits, although I have to say they're not quite as good, but we certainly can get it done and get your visit over with that way. Trophenite is a phase 3 study. We carried a phase 2 study several years ago. This is for 5 to 12-year-old Rett girls who get treated in a double-blind protocol called the Lavender trial for up to 15 weeks, including the screening visit, after which there may be there's a planned 40-week open label extension, which could go on longer if the drug is still in progress. A 30 to 60 milliliter twice daily liquid dose is given to target general Rett symptoms. Assessments at the visits include blood tests, questionnaires, an exam, and electrocardiogram. It's interesting that the chemistry of this disease is to, of this medication, is to be the last 3 amino acids, or essentially the last 3 amino acids of a hormone that we have that helps promote synaptic development and maintenance, IGF-1. So the medication is felt to promote synaptic growth and development, and maybe to decrease neuroinflammation. We've had 5 girls start so far, others are waiting, and 2 have finished the double-blind trial. Cannabidiol is another trial we have going. We haven't got any participants who've started at this point. It's for age group 2 to 18, and it is using an FDA-approved medication. Yes, this is the same medication that you can buy over the web or from state-sponsored stores, but the doses are generally higher, and it's with an FDA-approved version of the medication. Generally, when I've seen patients using cannabidiol as something they've purchased themselves, the doses are much lower because it's expensive. And of course, you're not quite as sure of the purity of it. This also targets general Rett symptoms, although this is a medication that has been approved for epilepsy in several rare conditions. It is not approved for other use or even other epilepsy. This may affect transmitter balance, neurotransmitter balance. It is given as a twice daily dose of liquid cannabidiol, CBD, in a 24-week double-blind trial, followed by a 6-month open label if the family wants. Assessments are by questionnaires, exam, electrocardiogram, and blood and urine tests. Ketamine is another open trial at Rush. It's for 6 to 12-year-olds, but it has to be prepubertal 12-year-olds. It is using an FDA-approved medication, approved since 1970, so it's been around a long time. We know a lot about ketamine. It's more recently approved for depression as well, for which in Chicago I hear lots of radio ads. It is an NMDA antagonist, meaning it inhibits one of the excitation neurotransmitters. The trial goes on for 8 to 10 weeks. There are several different dosage groups, and assessments are not only by exam and questionnaire, but also by biophysical sensors and electroencephalogram. 3 girls so far have completed this trial at Rush. A trial that just ended, and ended favorably, is the ganaxolone trial for one of the Rett-like diseases, CDKL5. This is a medication which is a small molecule that enhances one of the inhibitory neurotransmitters in our brain, the GABA neurotransmitter. Assessments are by a very detailed seizure diary, examination questionnaires, as well as blood work and electrocardiogram. The success of the trial showed that a 32% average reduction in seizures occurred to medication recipients, compared to a 4% reduction in those in the placebo group. So a very major difference in seizure reduction for the people who got the medication. And of course, everybody goes on the medication at the end of the double-blind trial. The company Marinus has proposed to apply for FDA approval, and so that looks like it will move forward in a positive way. We'll see what the FDA says. Another completed trial at Rush was a phase 2 trial, meaning focused more on safety than efficacy. This involved girls 18 years and older, and yes, there are some trials for Rett patients in this age group, but it is not ongoing at Rush at the moment. That's because we finished this part of the trial. Further trials are planned with younger kids. The duration of the trial was for 10 weeks using an oral once-a-day liquid, and it targeted general Rett symptoms. 4 patients completed the trial at Rush, and 3 are still in the open label phase. And the trial that has ended, we had a lot of fun and hard work with the Sarazotin trial. This failed to meet the primary endpoint of reduced apnea episodes in wakefulness, despite very promising mouse data. So we thought this would have some good benefit. We measured physiologic parameters using chest gauges that measured respirations during the daytime, but it failed to meet standards of improvement in that area or in the general Rett symptoms area. And we had about 14 participants in this trial. So I hope some of this interests you and that you want to learn more about this. So let me give you some numbers. If you've got a pencil or a pen and some paper, please note the numbers and the email addresses. We can say this again later if you didn't get it. Jeremiah Furman is our coordinator taking care of the natural history study and the Trophenite trial. 312-942-0079 is his number. I won't say the email address, but you can see it there. Katie Kudlas is taking care of the CBD trial, 312-563-9473. And Melissa Baer is currently managing the Ketamine trial, although someone else will probably be taking that over, at 312-563-6636. Now I'll leave that just for a second longer in case you're copying numbers or emails. Finally, I'd like to introduce our next speaker, Dr. Barry Kravis. Dr. Barry Kravis is a multi-professor at Rush. He's a professor of pediatrics, neurology, genetics, biochemistry. She has been interested in neurodevelopmental problems for her entire career, focusing initially primarily on Fragile X, but getting into other problems that she'll tell you about. She's got many research grants, some very large grants, and has just been moved to the Rett Medical Advisory Board. So we look forward to her talk today, and I'm sure she's going to illuminate all of us about the possibilities for where Rett syndrome research may go. So with that, let me hand this over to Liz.
Thanks, Dr. Heydemann. And Dr. Barry Kravis, if you'd like to bring up your slides and your webcam, we'll get started with you. And I really want, there's no better time than for me to say in front of your own people, welcome and thank you for chairing our medical advisory board. You are so well respected and world renowned for your work, and we are happy, so thrilled to have you work with our organization. Thanks for bringing your information with us today. We see your slides.
Okay, great. Can you hear me?
We sure can.
Okay, we're gonna do slideshow.
And thank you, Dr. Heydemann. While Dr. Barry Kravis is pulling up her slides, I want to especially thank all of the families who participated in the clinical trials that Dr. Heydemann spoke of. Our progress could not happen without you, and we know that it was no small effort on your part. So thank you very much. Okay, Dr. Barry Kravis, the stage is all yours.
Okay, I want to thank the Rett Syndrome Association of Illinois and rettsyndrome.org for offering to have me talk today. And what I'm going to do is I'm going to go on a little trip through Fragile X initially in this talk, because Fragile X started trying to bring new treatments based on the underlying disease to patients a little bit earlier than Rett syndrome. And I think we learned a lot of significant lessons in Fragile X syndrome that we're now applying to Rett syndrome and other diseases. So I'm going to talk a little bit about that, and then I'm going to move on and talk about the spectrum of what's becoming available in Rett syndrome and what kinds of strategies we have to treat or even try to, really target the underlying genetic defect. So translating mechanism-targeted therapies in rare neurogenetic diseases seems kind of easy. It's difficult, but a lot easier than moving things to people when you talk about changing genes or proteins or doing things in cell lines and even doing things in animal models. It's fairly easy to show that many of these agents that are targeted to some problem in the underlying disorder help the animal model. And then we think, okay, we got to get these drugs to patients and to help them to help the patients improve. But this is really a chasm, and this chasm is where I've been working for the last 18 years to try to move some of these targeted therapies to people in various different types of diseases, starting with Fragile X syndrome, but also now we've been working in Angelman syndrome and a number of neurodegenerative diseases, which often start out as neurodevelopmental disorders before they become neurodegenerative. And Rett syndrome, we've had a long interest in Rett syndrome. It's really kind of neurodegenerative at the beginning, but then becomes more stable and looks more neurodevelopmental. And all of these diseases overlap, and we can learn from each other in our work with all of them to help navigate the problems. So I'm going to talk just a bit about Fragile X syndrome. So Fragile X, for those who don't know, is the most common known inherited genetic cause of intellectual disability and autism spectrum disorder. It's on the X chromosome, just like Rett syndrome. It can be diagnosed with a simple DNA test, and it's due to this big mutation in the gene that causes the Fragile X protein or FMRP to not be produced. So it results from lack of FMRP, just like Rett results from lack of MECP2. So we have a natural history study in Fragile X as well, and we know from information surrounding that intellectual disability and behavior are the most limiting problems in Fragile X syndrome. And we also know that when our families rate how well their medications are working for them, the green ones are the only ones that feel their medicines are working pretty well, and seizures is the only thing we can treat pretty well in Fragile X. But we've got a lot of patients that don't really feel like things are working all that well. And when we survey the families about what do they need treatment for, they tell us anxiety, learning, behavior, communication. So things that overlap the types of problems in Rett syndrome, although motor-wise, the patients with Fragile X are more mobile and have more motor skills than patients with Rett syndrome would have. So there's clearly an unmet need in this condition for better behavioral treatments and for cognitive treatments, and we need to have better supportive treatment, and we would like to be able to treat the underlying disorder. Well, in fact, this is what we thought in 2002 when we discovered this mechanism of, and I'm not trying to, make this look too complicated or anything. The purpose of this slide is to show you the effort that's gone into treating Fragile X based on brain mechanisms. And so there's this glutamate that oversignals through a particular receptor, and as a result, the Fragile X protein that actually regulates protein synthesis in neurons, and so you get too much of these proteins, and then you get synapses that don't work as well. And so we have this mechanism, and so the point here is that we've tried to treat this mechanism with agents that approach it at all different levels in the mechanism. And in fact, these are all molecules that have been used in animal studies to try to reverse phenotypes or characteristics that the animal model of Fragile X actually has. And in fact, all of these drugs have reversed phenotypes in the animal model. So the animal model is a little bit easier to treat than humans are. And we've done clinical trials of this list of circled drugs in Fragile X. So we have quite an experience. We've figured out pretty much every way to fail at treating the disorder, but we've also learned a lot, and we have some successes that are emerging. So we've gone to phase 3 or late phase 2 trials with 3 drugs. We have a bunch of things in red here that have not moved forward because either the drug didn't have enough effect or there was no drug development pathway. And the green things are things that are still in development. One, which is the Trophenite or the Acadia drug that's in Rett syndrome, as well as a few other things. And I think we're seeing more successes in more recent trials just because we've learned a lot from the previous trials. I'm going to show you 2 of the drugs that went to late trials and then never got approved, just to give you an idea of how much work goes into getting these drugs to almost approval, and to give you a little bit of an idea about how difficult it is to translate from animal models to humans. So for these mGluR5 blockers, which were, kind of a great hopeful drug in Fragile X, there were a huge number of mouse studies. This is the list of characteristics in the mouse that are abnormal in the Fragile X mouse compared to normal mice that were reversed in various studies. And there were examples of things like audiogenic seizures and epilepsy in the brain that was reversed, and the dendrites, the neural structure was changed to be more normal. And overall, there were a huge number of papers, over 40 papers from 20 labs, that show that you could reverse 90% of the things the Fragile X mouse had that control mice didn't have. And we could reverse 6 characteristics of the Fragile X fly and 6 phenotypes by genetically correcting the mGluR5 receptor, and phenotypes reversed in the Fragile X rat. And so you would think from all this body of preclinical data, we should be able to translate this to humans, right? And in fact, when we were coming out with all this mouse data, we had one Fragile X dad that came in the clinic and he said, darn it, it's a great time to be a Fragile X mouse. So our goal was, of course, to try to have it be a great time to be a Fragile X kid. So we did some human trials, and the first trial was very encouraging. We showed we could change a sensory measure with 1 dose of an mGluR5 blocker called Phenibom, and that shows target engagement. In other words, it shows the drug is getting into the brain and doing something to try to reverse the disorder. Then we did these big phase 2B placebo-controlled trials with both Roche and Novartis, who had different mGluR5 blockers, and these failed to show change in behavior in adult and adolescent studies, and Roche and Novartis disbanded their programs. But this was focused only on behavior when we had a mouse model telling us that we were changing neurons, and maybe we should have been focused on something else. And so we had a sub-study at Rush and UC Davis where we actually showed that we could improve the ability of the patients to look at the eyes in an eye tracker, and we could improve the impulsive behavior on a computer-based test of inhibition. And so it looked like the drug was targeting the disease, but maybe we just weren't studying the right thing. And when we talk about a drug that's going to impact cognitive functioning and a developmental disability, maybe we're not studying the drug at the right age. So after thinking about this a lot, We actually have a trial right now, which is funded by NIH because none of the drug companies will do it, to actually study one of these mGluR5 blockers and the effects of it on language learning in little kids with Fragile X. And so we have a long treatment period, and we're doing a language intervention coupled with a placebo-controlled trial with the drug to see if the drug amplifies learning. And this is actually the first ever large multi-site trial studying the effects of a targeted drug treatment on learning, and will actually be a model for multiple other neurogenetic diseases, including Rett syndrome, for how to do a trial like this. So the other trial that went to late development in Fragile X was our baclofen. And this also showed multiple benefits in different areas in the Fragile X mouse. And so we went to the FDA. This was the first Fragile X trial. We went to the FDA and they said, oh, they use the aberrant behavior checklist for autism. You should use that. And then pick the one behavior that might get better. We're not going to let you look at the whole disease. And that was a problem. But we did use the checklist because that was all they would let us do. And we did see improvement in the social avoidance part of that checklist. And then we had this nice novel measure where we asked the families to rate the 3 most awful things they didn't like about their Fragile X child. And that actually showed the best improvement on this drug. Unfortunately, the FDA told us, no, they didn't like that measure because it wasn't just one behavior. So we went back and ran 2 phase 3 trials, one in adults, which did not show benefit, and then one in children, where in the highest dose group, and this was also a problem because the FDA forced us into a dose increase to different groups on different doses, where 2 of the doses were not therapeutic. But we did see benefit in irritability and parenting stress and a variety of other features in this pediatric trial. And unfortunately, the primary outcome was social avoidance, which didn't quite meet statistical significance, probably because we had to enroll less patients in the trial than expected because the company went out of business. But with this drug, we saw some interesting things, whereas all of these measures of behavior on different questionnaires actually improved more than the average effect size of most of the approved SSRIs for anxiety. So this drug has a big effect, but we couldn't do a big enough trial to get statistical significance because we have a rare disease. Also, we looked at some of the patients who went into an extension and got to take the drug long term. And normally in Fragile X, adaptive behavior scores go down because the patients don't keep pace. They're not deteriorating, but they don't keep pace with their typical peers in terms of their ability to develop life skills. And during the 1 year of treatment on our baclofen of a small group of 30 patients, instead of going down in red, these adaptive skills actually went up a little bit or went down less. And so it looks like there may have been a long-term effect of the drug that we couldn't pick up in the trial. And then we had some patients with a magical response. And in a neurodevelopmental disability, it's a magical response when you tantrum all day long every day and are on multiple drugs to stop that. And then after you go on a drug, you run a 5K run and go on Magic Mountain at Disney World. So we do know that in certain patients, this drug had a very magical effect. But again, there were responders and people that didn't do as well. And so that's an issue. So this is me after all these trials. And why did massive number of studies in all these animal models and target engagement in humans not translate to an FDA approval for Fragile X? So there's a big list of things that might have gone wrong that's really important for us to understand in Rett syndrome. So there were big placebo effects. We had the same measure to qualify people for the trial as the primary outcome. And unfortunately, families figured out how to rate the measure and gained their entry to get into the trial. And then that doesn't help us because then that just compounds our placebo effects. There were only some patients were responders. The outcomes, some of these kids improved in language and we didn't have any outcome measures to pick that up. The FDA precedents like fixed doses and the one behavior were really a problem for trial design. The trial wasn't long enough, and because of commercial problems and the company going out of business, there weren't enough patients in the trial. The mGluR5 blockers, we may have been studying behavior when we should have been studying learning. There were also huge placebo effects. We did questionnaires that are highly variable to start with in multiple countries and cultures, and that was a problem and amplified the placebo effect and the variability. And then it's possible, and none of us like to think about this, but the mouse model might not be predictive for human response in neurodevelopmental disabilities, but it's hard to believed that all that work would just not be predictive. So we've had some lessons from Fragile X that can be applied to Rett syndrome. And basically in Fragile X in 2002, we were kind of building the bridge while crossing it, and it wasn't clear where the other side was because there was no template for trial design testing a disease-modifying treatment in any form of intellectual disability or developmental disability. So what have we learned? We have learned you need a good, consistent clinical trial infrastructure with multiple sites that are doing measures and methods consistently, and we have that now in Fragile X, the Fragile X Clinical Research Consortium. We learned that the FDA is not all it's cracked up to be on super rare, untreatable neurodevelopmental diseases, and we need to argue with them. We learned that treatments modify the whole disease and not the one behavior, and this is one of the things we have to argue with FDA on, and that behavior and cognition may not always track together, that there are often responders, a group of patients that do well on a new drug and a group of patients that don't do as well, and we have to be able to account for that. And we need to measure response in the whole condition because one patient may respond with respect to one symptom and another patient may respond with respect to another. And then sometimes side effects can interfere with the measurement of response, and we need to deal with that. Placebo effects are the enemy. Whenever we can have an objective measure or standardized interview or coded naturalistic samples, this is better than just having ratings because we all have placebo effects, including the doctors who are rating the patients as well as the families. We all want things to work. And don't enroll people on the same measure as the primary outcome. And then managing social media was something we really learned in the Baclofen study because patients communicated with each other in ways that were problematic for the trial. And I think everyone needs to recognize that that can be an issue. More of the lessons, we need biomarkers to try to figure out who are responders. This is the holy grail of every neurodevelopmental disability, a biomarker that tells us who is going to respond. And this is even better if we can measure the biomarker in the animal model. Mice are not men. Mice have died before men go to preschool. So they may not always predict the time course or the benefits in a certain age group, like adult mice may not predict adult human benefits. And so developmental disorders require starting young with targeted treatment to have the biggest, fastest, most measurable impact. And measuring cognitive and developmental change is going to take time. You can't do a 2-month study. You're going to need to do a 1 year or more study. And sometimes to speed up learning, if we embed a learning intervention, we can speed up learning and we can see the drug effect on learning or on synaptic plasticity that is behind the learning. And so how have the Rett trials approached these lessons? So believe me, the Fragile X field and the Rett field communicate a little bit. And Rett had a lot of things that they were building even while we were doing all these trials in Fragile X syndrome. There's a natural history study in place to help define long-term outcomes and even new measures and biomarkers. There's a clinical and research trial network that's emerging from the sites in the RDCRC, and that's really the work that we're doing with rettsyndrome.org. We have a composite measure of the entire disease was used in the original neurin trofinetide trials. But unfortunately, they gave in that development process gave in to the FDA on a single measure for phase 3. But this composite measure of the entire disease was really a good idea. And I think we're still working with FDA on strategies like that. The Rett natural history scales have been modified to quantify change better, and Jeff Newell and Alan Percy and others have done a lot of work on that, particularly for the Neuron and Acadia studies. And then measuring clinical impression of improvement in a standardized way across all the evaluators is tremendously important, and there's been a lot of work on that, including measures of hand use, walking and gross motor skills, verbal communication and communication of choices. And some of the trials have gone to young ages really early on, which is very important for developmental disorders. And then they're using inclusion requirements are based on different scales than the outcomes. So I think these are all ways where we've been able to improve trial design for Rett syndrome just based on past experience. There are things that are still going to be a problem. Placebo effects, especially if a drug has a side effect that can be unblinding. And this is difficult in Rett because they're not really good objective cognitive outcomes, because that's been very challenging to do in Rett syndrome. And I think work on some computer and eye tracking based measures is underway, and that will be very good to develop. We need biomarkers for both target engagement and responders, and we don't have that yet. And there's work to do with FDA on measuring the whole disease with composite outcomes and comparing to natural history, and ways of doing learning interventions in a targeted treatment trial has not really been explored yet in Rett syndrome. So there are a number of drugs in development in Rett syndrome, and I think to put this all in perspective and try to get a picture of what's going on in Rett syndrome, it's useful to categorize these. So for Fragile X, I just talked about targeted treatments that were supposed to impact this neural mechanism that had been discovered. But for Fragile X, as well as Rett syndrome and other neurodevelopmental disabilities, there are multiple categories of treatments being developed to either try to improve supportive treatment or target the disease itself. So these categories I think of as being supportive treatments, like this is a treatment that will improve your care and quality of life, but it doesn't really specifically target a mechanism in the underlying disease. Or a neural mechanism-based treatment is another category where we know a little bit about the mechanism in the Rett mouse and in the brain. And so we're going to use a drug that has a specific reversal of a certain mechanism that's abnormal in Rett syndrome. And some of these are general mechanisms that just improve the ability of neurons to communicate with each other, and some are Rett specific. And then there are those genetic strategies, and these are the pie in the sky things that are going to actually reverse the actual genetic deficit in the disease, like gene therapy, gene reactivation, changing splicing of RNA, and CRISPR-Cas mutation correction. And so the goals and outcome measures in a trial would be based on the type of agent and what you expect the agent to do in the trial. So with that in mind, I think there's one other issue that Rett syndrome has in terms of developing biologically based drugs, which is that we have to deal with the Rett biology. And the Rett biology, as we know, is that Rett gene is on the X chromosome, and in X inactivation, you shut down one of the two X chromosomes in each brain cell. Either the mutated X or the normal X is shut down in each brain cell. So all the Rett girls are kind of mosaics that look like this, where there are some cells with, like the white ones, with no MECP2, and the red ones that have MECP2. And so when we have this kind of mosaic situation, and the percent varies in different girls with Rett syndrome, the issue of normal MECP2 in a percent of cells for a disease-targeted mechanism of a drug is, or for gene therapy, is important to consider, because you want to make sure that the drug that's correcting a problem in these cells without the MECP2 is not causing a problem in the cells that have MECP2, and that's something that has to be thought about in development of new treatments for Rett. So with that, I'm going to run through the treatments that are currently in development and kind of put them into those categories and show you a little bit about what they do in the brain. Peter ran through some of these, and I'm just going to do more detail on kind of what the mechanism of the drug is. He gave you the details on the trials. So cannabidiol from GW, which is the same preparation as Epidiolex for seizures, is targeted to anxiety and behavior, and they're tracking seizures also. And this would add to the medications we currently have for Rett behavior and might concurrently help with seizures. Often we can't get Epidiolex for Rett because the seizures, we don't have the right EEG pattern, and the drug is only approved for certain things. So this would be, I think of this as a better supportive treatment that might help with some of the problems in Rett syndrome. There are a number of drugs that are targeted to the neural mechanism. One is the Trophenite trial, which was with Neuron and now with Acadia. Again, as Peter said, it's a growth hormone analog, but it doesn't work through the growth hormone receptor. It works on this pathway called the mTOR pathway, the mTOR-AKT pathway, which is deficient in the Rett mouse due to absence of MECP2. And so it reduces the expression of some of these growth factors like interleukins and TNF alpha. And there were positive findings in the Rett mouse. And for instance, this is the Rett mouse. This is a Rett mouse neuron without trofinetide, and this is a Rett mouse neuron with trofinetide. So the neurons seem to be sprouting these nice dendrites that were increasing connectivity in the brain. And so in the phase 2 pediatric Rett study, there were a number of measures, and here down is better. And so this darker green line is the patients who are on drug, and the lighter line is patients on placebo. So in multiple measures, Rett syndrome patients did better in a blinded trial in this pediatric study. And the initial phase 1/2A trial, which was in adults, also met its primary composite measure. So this composite measure of a group of different outcomes showed improvement, and these studies were both successful. And so now this drug is in phase 3 for FDA approval, and hopefully the phase 3 study can demonstrate the same positive effects. Another neuromechanism-based drug is ketamine, which works on this receptor called NMDA. So basically, there have been evidence that NMD receptor blockers like ketamine can increase neural connectivity and work on brainstem networks for autonomic and respiratory control. And there's data in the Rett mouse that shows that the drug can improve brain circuitry and increases deficient BDNF and mTOR signaling. So again, mTOR is one of those things that we want to decrease, and it looks like this drug may do that. So basically the mechanism of ketamine is that normally in a typical situation, NMDA receptors have this pathway through which they block BDNF, which is a neural growth factor. BDNF is already decreased in Rett syndrome, so it's like making a problem worse. If we put in ketamine in here, that blocks the NMDA, so it can't block the BDNF. And then we get more BDNF in the Rett patient, and then that results in improved connectivity at the synapses and in creation of more of these, dendrites and synapses, like I showed with what trofinetide is supposed to do. So then there were some anecdotal patients with Rett who had seizure control and substantial functional improvements when they got a dose of ketamine. And so now we are in a phase 2, very early phase placebo-controlled trial for short-term dosing, just to look and see if there's a signal in a population with Rett, and if we can find clinical and EEG biomarker improvements. And so that's what that trial is really all about, is to see if we should go forward with a bigger trial. The Anavex 273 drug is a sigma-1 receptor activator, which works on a bunch of those signaling pathways that I've shown you in previous slides and restores neural balance and cell signaling that's abnormal when MECP2 is absent. And so this is the Rett mouse. This is the hand wringing, the mouse hand wringing, and the mouse does these stereotypies with its limbs, and that comes down nicely on Anavex 273. And then this is the stride when the mouse is walking. They measure the stride length, and this is the normal. The yellow one here is normal mice, and then these are the Rett mice, and you can see that the Rett mouse is looking more like the normal mouse after it's on the Anavex drug. So there may be some effects on hormonal systems that overlap, growth hormone and BDNF, and there was improved motor function, balance, hand wringing, apnea, sound and vision responses in the Rett mouse in a single study. And so this is now in a phase 1/2A study, and as Peter mentioned, this is closed, and we'll see what the results show us. Genetic strategies. This is what everybody has been looking for in rare neurogenetic disorders. So one genetic strategy is that sometimes you can have a mutation that changes the gene product so that the gene is supposed to make this product, but then one of the exons of the gene, the protein coding parts of the gene is spliced out, and then you don't get the right product. Well, for instance, in SMA or spinal muscular atrophy, this happens all the time in virtually all of the patients. And so they've created an antisense oligonucleotide that changes the splicing and you can get the normal RNA product. So this is one way to genetically correct a disorder. And this works great in spinal muscular atrophy because like 95% of the patients have all the same mutation. In Rett, this could theoretically be done, but only with certain very specific mutations. It's not been tried because it would only target a small subgroup of Rett patients. We could also correct the mutation itself with a CRISPR-Cas strategy, and that's those reagents that go into brain and take out the mutation and put in the right nucleotide. But this is you can get this to work on cells in culture, but this is very hard to get to work on a large percent of brain cells, and has not really been successful yet in any brain disease due to issues with getting the reagents into the brain and the proper neural cell delivery. So what might be more possible? Well, gene reactivation has been talked about in Rett syndrome. So the idea here would be that you would reactivate the MECP2 gene in brain, not the whole inactive X chromosome, but just the MECP2 brain on that inactive X chromosome to give you one active MECP2 gene then in every cell. And so that would work like this. You've got the active X chromosome, and it's making the mutated MECP2 protein, so that's causing a problem in those neurons, and the inactive X chromosome is not making the normal MECP2. So you would put the activating reagents in, the MECP2 gene would be activated, and you would make normal MECP2, and now every cell would have normal MECP2 in it, and that would be just great. So this has worked to reactivate the paternal UBE3A gene in Angelman syndrome, but the mechanism of inactivation lends itself to easy treatment with the ASO, and this would treat all the patients with Angelman syndrome theoretically, or most of them, based on this mechanism. So although this has been successful in the basic science studies and preclinical studies in Angelman syndrome, there's been some progress in Rett syndrome. This would only work for girls with Rett syndrome because boys only have the 1X with the mutated gene. And so the MECP2 has been activated on the inactive X in mice, but the problem is this has to be really specific for MECP2. You can't reactivate other things on the X chromosome, or you could get other diseases like cancer. So it has to be very specific, and you have to get these reagents to a high percent of brain cells. And so again, access in the blood-brain barrier can be a problem. In theory, this could be very successful, but work needs to be done to make it happen. And so the final thing I'm going to talk about here is gene therapy, where we would replace the entire MECP2 gene. And this actually is underway. You've heard things about this in various posts and things. Avexis and Novartis are now working together on this. It's been successful in the MECP2 mouse with expression of the MECP2 protein in brain and improvement in some deficits in the MECP2 mouse. The hurdles of gene therapy, and this is where we take the gene and we put it in an adenovirus vector, and the adenovirus vector is tropic for brain cells. So it goes into the brain cells, and then the gene comes out of the vector, and the vector is inactivated so that it can't infect the brain. And then the gene goes into the DNA and makes the protein that you want. And so they can show that they can make more MECP2. This is the amount of MECP2 being made off that gene in a animal model. And then this is the mouse, and you can see as things get more green, the mouse is making more MECP2 there. The mutant mouse. So you can correct the MECP2 deficiency in mice. So this is moving forward. The issues will be the human brain is bigger than the mouse brain, and getting the drug through the blood-brain barrier and to all the cells in there. And often, sometimes if you can even get 90% of the cells in mouse, it's hard to get better than 5% in humans, but techniques are getting better for this. You have to get it into the brain, so you have to give it by a spinal tap or through a port into the spinal fluid. You have to get the right amount of protein in each cell. Could be having too much MECP2 be a problem, like if you put the gene into the cells where the MECP2 normal gene is the active X chromosome, and then you have double the MECP2 in those cells. And you have to make sure where the gene goes into the DNA doesn't cause other problems. This will probably work best the younger the patient that we try it on. And early studies are coming soon, and we'll try to address, the early studies will best be to get an understanding of how all of these hurdles are being addressed and how well are we being successful with gene therapy. It will be a very intensive trial when it comes out, and we do hope to be one of the sites on the first gene therapy trial. So with that, I'm just trying to give you an overview of what's coming in the future. I think we are going to get better with these genetic strategies, and they are very hopeful, but we do have challenges both with the technique of delivering the genetic therapy and with the way that we are measuring how the Rett patients are improving, as I kind of focused on in a lot of this talk. We hope to have multiple levels of treatment in the future, including the supportive, the neural-based treatments, and the genetic treatments, and they are probably all going to work best when they're used together. And there are examples of this in other diseases that show us even when you have gene therapy, it works better if you combine it with a substrate therapy or some other kind of therapy. Why? Because that gene does not go into every cell in the brain. We have work to do with trial design, the FDA, natural history, and the best outcomes to measure, and biomarkers particularly. And we need to work together with families as our partners to make all this happen and move forward toward multiple treatments. And your participation and collaboration with us in research is the key to the future of Rett syndrome. And that's all I'm going to say, and hopefully I'm not way over time.
Dr. Barry Kravis, I could listen to you all day long. Thank you so much. And your words per minute, I think, are the fastest of anyone I've ever heard. So thank you. I don't know how much coffee it takes to get you that amped up, but I'd like some, please. So,
all right. Sorry if I was going too fast. I do that naturally, and I try to slow it down, but sometimes it's difficult.
That was not a criticism. That was an appreciation. And you covered a lot of information, and we will have you back many times to review this information and give us progress updates. And thank you for being honest about the challenges of science and research. But through all of that is huge threads of hope, of progress, both for Fragile X, for Rett syndrome. And again, I have to say to our families, as well as to our researchers, we're at an incredible place where it's come together, where none of this would have happened without the participation of families, both destroying trials and being complicit in trials. So what I'd like to do now is bring the slides back to my desktop. And in the interest of time, I'm going to go a lot faster with our town hall update of the things that we've made progress with at rettsyndrome.org over the summer, but I'm going to turn my webcam back on here. Okay. So that we can get to your questions, because I know that we have a lot of questions that were submitted, but we have a lot of great tools that are available to you that came out over the summer. So most of us are familiar with rettsyndrome.org. If you're not, if you're new to our organization, understand that our mission is to accelerate research while empowering families. We know that these two things are not mutually exclusive, that while working on how to treat and cure the disorder, we have to live with it today. And one does not take a part away from the other. In fact, they contribute to each other and help it advance mutually. So we have not abandoned that mission, and it is stronger than ever in terms of empowering families, contributing to research, and being your advocate, both nationally and internationally. In terms of accelerating research, I think you've heard from Dr. Barry Kravis, and this is why she is chair of our medical advisory board, that we believe in full spectrum research. We think that we need to attack this syndrome, this disorder, from many ways, from whether it's communication, neurohabilitation, learning how to move better, sleep better, breathe better, to treatment medications that will help with those symptoms if therapies don't help, and ultimately gene therapy we hope will be a major solution. And again, none of that is mutually exclusive, and we have experts in various fields who have moved that from basic to translational to actual clinical trials. And over the summer, a lot of progress continued to happen. If you'd like to visit our website, you can see more information on what research we have funded. Some great research recently was announced. We have some inside the lab features, which give you a really nice, personal, deep interview, if you will, with some of our researchers to let you know that they are human beings inside their lab coats who care very much for our families, and they share some of the stories about what brought them to Rett syndrome. We also have the Scout program, which is unique in the field and is a really great tool for the community and our medical advisory board, which again, you're so lucky to have Dr. Barry Kravis right there with you in Chicago at Rush. Dr. Heydemann talked about our Rett Research Ready program. We worked really hard on this over the summer because we heard from families that, wow, we went from having no clinical trials to multiple trials and research opportunities that you could participate in, and it got overwhelming. Is it for an adult, or is it for a child? Is it for a male, or is it for a female? What is the criteria to enroll? Now, where do you get your information that you can trust? Clinicaltrials.gov is the ultimate place to get that information, but that's a pretty difficult site to navigate. And so we created a funnel, we created a portal where you can go to our website for the Rett Research Ready program and find all kinds of information that is very Rett specific. The My Rett Trial Finder specifically is a place where you can sign up, put in some criteria about where you live, a little bit about your child, and help be directed to what's currently active and get your name on a list. If you join us on Tuesday, this coming Tuesday, October 13th, you can spend some time with our Chief Science Officer, Dr. Dominique Pichard, who has joined our organization. Many of you have not had a chance to meet her in person, but when Dr. Steve Kaminsky retired, she was his top recommendation to come into the position. She worked at the NIH and worked on another rare disease and was very well regarded in her field. She also has a child with Rett syndrome, so she brings both the personal and the professional to the position. And she's going to spend some time with us on Tuesday, giving a real orientation and tour of the Rett Research Ready program, why that's important to you, why you should become familiar with it, and how to navigate through the Rett Trial Finder. It's not difficult, but if you're like me, I need someone to really kind of show it to me before it clicks and we participate. Okay, the other side of our mission, empowering families. We know that this journey is very lonely if you are not with a cohort. And we know that most of us don't have someone with Rett syndrome who lives down the street or attends the same school as our child or our church. And we have a virtual community because of our rare disease that is better together. We are committed to providing information that supports you on your journey with the latest medical information. Funding research, thanks to all of your fundraisers. We direct as many dollars as we can to research, and then we use the collective knowledge of our community to empower families with that useful information about how to live with Rett syndrome in our houses. And we also commit to raising public awareness and advocating for all living with Rett syndrome. A couple of the things for empowering families. I hope you're all familiar with these and are receiving them. And if you have not, please sign up with us and get your hands on our Rett Gazette newsletters, get the handbook, visit our website. We have so many resources. We have a state rep. I'm going to let you meet Shelby in a few minutes here, who's right there, who's most familiar with things in Illinois and the surrounding area, to help you connect with agencies and nonprofits that deal with many more syndromes than Rett syndrome, but can help you get access to equipment and respite and IEP support and all kinds of things. We also know that Rett syndrome is a complex disorder and really hard to explain to people, so we have some things to help simplify and bridge and accelerate you to go from less stress to more success in your lives, such as the Rett syndrome handbook, but getting some personalized awareness cards. It's like a little business card that you can get where we have a description of Rett syndrome, and you can put a picture of your child and a little story about your child on the card, and then you can hand that out when you're out, when we can all be out in public again, right? And people ask and they want to know more, you give them that card, and then they can go to our website and learn more. And we can make all of these things available to you to help. Now, what happened during COVID? So back in the spring, when suddenly shelter in place happened and we were all sent home, most of us were at home without any of our normal supports of therapists, doctors, the equipment that was in our schools or day programs, access to clinics and therapies. So we brought some of our world therapeutic experts into the homes of families via webcam, and we recorded those sessions. They were brought on Facebook Live. Hopefully you saw them. Well, you know what? Those sessions were relevant before shelter in place, and they are still relevant now, and they're all recorded and they're on our website, where we have actual therapists working through the camera with parents, showing how to use things at home, like your couch, your wall, a stool, a therapy ball, your backyard swimming pool, to do moves and stretches and how to communicate and how to engage with your child. And we're going to move those out of the COVID world and into our standard digital library of materials. So take some time and go and check out those videos, because they're really, really very good. Okay, we've also been providing periodic community updates from our medical advisor, Dr. Tim Benke, who has taken the collective knowledge of our clinic directors from around the country to give some legitimate, if you will, advice that you can take to the people in your circle about what's going on with Rett syndrome and COVID, how they're interacting or not interacting, and what to do about that. So our standard programming, which we really started a year or two ago because of the nature of Rett syndrome being a rare disorder, is a Rett Ed monthly webinars, and that translated so perfectly well to this time where we can't be together in person. And we didn't let up, we didn't stop, and it's going to continue to be a core program for us moving forward. All of those monthly webinars are recorded, and on our website we have a digital library of probably 20 or more sessions now that we can go specifically into topics like epilepsy, Rett spells and episodes, movement disorders, nutrition, all kinds of things, quality of life, self-care. We have lots of those, and we have future webinars coming up. Like I mentioned on Tuesday, we're going to hear from Dr. Dominique Pichard about a little bit more about clinical trials, although you got some great information today from Dr. Barry Kravis and Dr. Heydemann and Dr. Buhrfiend, but you'll get that Rett Research Ready orientation. In November, we're going to go over the communication guidelines and talk about those in a second. And in December, we're going to hear about what do they see, vision and Rett. We hear a lot about CVI, cortical visual impairment, and CDKL5. A related disorder to Rett syndrome, but we haven't really talked about it in Rett. And so we're going to see some of the first information and publication in studies about this in Rett syndrome. So we hope you join us in December. Again, all of our Rett eds are free, and we thank our sponsors for helping us be able to do that, because we think all information should be free to those who wish to avail themselves of it. Guiding care, primary care guidelines. This is huge. One of the questions submitted that we'll get to in a few minutes is, how do you track symptoms in your child, and how do you know that you're getting the correct exams and tests for what symptoms commonly happen in Rett syndrome? Well, we had a collective group of people publish the primary care guidelines, which is a consensus document about care in your child. This guideline will help your pediatrician, it will help your general practitioner, it will help a gastroenterologist understand what could be going on with ortho, cardiac specialist understand what might be going on neurologically. So look for the primary care guidelines. We also have pamphlets on scoliosis and nutrition and digestive health, and these are all on our website. The communication guidelines. Okay. We talked about neurohabilitation. Here is this beautiful guideline. This is the culmination of 5 years of research from over 600 professionals and families worldwide across all ethnicities, across all geographies, contributing to an understanding, evidence-based, scientifically supported, that our children can communicate, that our nonverbal children have a lot to say, and there's a lot of ways that we can tap into it. And this guidebook is a really great workbook that can you can purchase or download from us. We accelerated publication so that right after shelter in place, it became available. And now that school has started, we really hope that you'll get a hold of these guidelines and give it to families, not families, to your educators and folks working, SLPs, AAC specialists working with your kids. It goes through how to assess communication potential. Every child is unique. Our kids are multimodal, sometimes low tech, sometimes mid tech, sometimes high tech is best. How do you know which is best? This guideline will help accelerate, again, getting you quicker with less stress and more success. So get your hands on the guidelines. All of our fundraising events have contributed to the research progress and production of programs that we're able to do. Most of our events have had to go virtual this year, and we are really excited for the Rett Ride Across America program, which is happening throughout the month of October. We encourage you to please participate. Everyone in your family and community want to help, and they are just waiting for you to show them how. So by joining a virtual ride or a community ride, you can get donors and supporters to support you, whether that's just your child getting on an adapted bike and going around the block, or doing a COVID-safe community ride. You too can contribute to the success of all the wonderful things you heard about today. We hope on October 24th, you'll sign up and join us for a virtual gala. We're going to hear from some families. We're going to have some multimedia presentations. It's going to be a really fun night. If you register by October 11th, so by the end of this weekend, we should be able to get you a really cool beer pint or wine glass that you can fill with the beverage of your choice, and sit back and relax and enjoy some really heartwarming stories about Rett syndrome and hear about the progress we're making. It would be totally remiss of me to not acknowledge and celebrate that October is Rett Syndrome Awareness Month. This is the month where you can raise your voice, you can participate in all kinds of campaigns and activities, you can purchase merchandise from us, you can wear Overpower Rett tattoos, you can share personal stories on social media, which is the best way to get people to really understand what's going on with your child and with you as a family. And we hope that you tag every one of those posts with hashtag #OverpowerRett to get it trending. This is our 3rd year of using this campaign, and it's really taking off and being used worldwide. So participate in October Awareness Month, please. Now, what I'd like to do is invite Shelby Sawyer to come on for a moment and talk a little bit as your rep for the state of Illinois. We do have reps in every state. We know that we have more families on our call today than just Illinois, but we're going to focus on Shelby because she is a rock star. And I'm going to turn off my webcam and go on mute and let Shelby tell us a little bit about her family and ways that you make yourself available to help others. Thanks, Shelby.
Hi, everybody. It's so good to see you guys all virtually. I know I'll be checking this recording out later myself. I'm going to make this really quick. First of all, I want to thank very much personally the doctors that have made presentations from Rush University. We have been with Dr. Heydemann since Kendall was about 2.5 years old. We see every doctor at the clinic, and they're all fantastic. Kendall is a healthy Rett girl because of each and every one of them. So thank you, and all of you, for taking your time on a Saturday to talk to us. We appreciate it. On my slide, I just have here a couple of ways you can contact me. I talk to a lot of newly diagnosed families, but any of you can call me anytime. Reach out on our Facebook page, my cell phone. You can call me, text me, leave me a voicemail, email, whatever is your preferred way of communication. I can certainly try and help. Join the Illinois Family Rett page on Facebook. It's an active group. We like to go there just as parents to voice our frustration about why our Rett girls and boys are driving us crazy that particular day. Sometimes there's advice there that can help us get through a situation a little bit quicker and easier if the docs aren't needed. From the standpoint of what is available here in Illinois, and this kind of goes outside of Illinois as well, I highly recommend that each and every one of you teach your child, your Rett child, to communicate medical need early on and always, often, because many, many times the insurance companies cannot deny a child that is communicating medical need. It was something that somebody offered to me as a piece of advice. Kendall is so good at saying, my stomach hurts, my head hurts, I don't feel good today, I need to go to the bathroom, which is our biggest one, as you guys all know. So please, if there's anything that I can recommend to you as a young family or even a family with a teenager, is get those visual cards out in front of them or on their device. Let them communicate medical need. It really will take you far in requesting all kinds of different things from the insurance and our doctors. Our doctors want to hear what our kids are feeling too. We always carry a 5 to 10 page eye gaze book for quick reference for Kendall when we can't take out the computer, or she's feeling frustrated at the doctor's office. She's hot because it's 110 degrees in some of those rooms at Rush. She always has something quick to communicate what she's feeling. As far as the puns list goes, that's something at any age as well. Please, you guys, if there's anything that I can ask you to do as a Rett parent or a parent of a child with special needs, get on that puns list, put it in your calendar, remind yourself, call the puns people every year to get you on that waiver. We have the waiver in Illinois. We are taken care of tremendously by it. I know a lot don't get pulled and it's frustrating, but if you don't call and make sure you're on the list, you won't get pulled, and nobody else is going to concern themselves with you if you don't do it. If you need to know what location to go to, I have access to that. It's also on the DHS website. I'm more than happy to look for you and give you all the information. So please make sure you're on the puns list each and every year. The second thing, for the state of Illinois, I would like you guys, I have a 16-year-old daughter with Rett syndrome already. Marie Kroll is my first contact in the Rett world as far as helping us. And Marie, that was so long ago. Kendall was only 2.5 when we met you, and we got thrown into the Rush Clinic, and Dr. Percy was our draw. And how lucky are we to have had him and Jane at our traveling clinic. But I am a little out of the loop with these new kids and all of the new things that they're going through. So if anybody wants to help us co-state rep this state for me and help new families and help existing families and families that have kids that are my age, I think Jill Yoakum is close to my age, Paul, if not maybe a little older. I can't remember. I'm 47. So you guys, thank you for all that you do for me. Also the fundraising, I'm all over the place, sorry, but fundraising, who can fundraise? You can, any one of you, $5, $10, $100, t-shirts, campaigns. You can do the lemonade stands that rettsyndrome.org sets up easily for you anytime, but October is a huge time for giving. We're up on the giving season already, believe it or not. So please, rettsyndrome.org does a lot of these things for us, and we need money for a cure, and we need money to do these things with all these doctors and scientists that are helping us. So with that, I'm going to end real quick, and I appreciate, again, all of you and Paige for inviting me, and I look forward to hearing from each of you soon. Thanks.
Gosh, thank you, Shelby. And you are a really amazing person, mother of 3, taking care of one with some pretty severe special needs, and yet you have found it in yourself to give to the community. And I know that what you get back is far more rewarding. And I say that as someone who started as a state rep in California myself. So thank you for everything that you do. Families, take advantage of Shelby and take advantage of our friends at the Rett Syndrome Association of Illinois. I invite Paul Yoakum to give us a little update from his foundation that he started, and many others have continued, and they are here serving you on your behalf. So Paul, thanks for joining us today. Tell us what's going on at RSAI. Oh, Paul, hold on. We can't hear you. You're on mute. Let's see if I can open up your mic for you. Nope, I think you're gonna have to do it. Right.
Okay, testing, can you hear me?
Excellent. Stage is
Okay.
yours.
All right. On behalf of the Rett Syndrome Association of Illinois, I'd like to thank everybody for joining us here today. Right, it was 31 years ago that Janelle and I hosted the first meeting for Rett families in our living room. So, and as Shelby was saying, that Jill's 44 years old now, and we've learned a lot in those years. We have one other daughter that's 42. But Jill's taught us a lot of patience, compassion, and what unconditional love is all about. She's changed our lives and taught us to be thankful and grateful for the little things in life. And sometimes you don't learn those until you go through some tougher times. Just a little bit about RSAI. We host 3 free events a year. In February, we rent the entire swimming pool in Elk Grove Village. And after everybody goes swimming, we have food. In the summertime, we do a picnic down in Oak Brook. And of course, there's food after that. And we rent a petting zoo and horses to come in to give all the kids rides. And in the fall, we do bowling at Pinstripes. And of course, there's food. And sometimes we have a Halloween costume contest, but not this year. But we use an email service called Constant Contact to get our information out to all the parents. And one of our parents, Anna Valu, does a great job on that for us. Special thanks to Paige, Paige from the Rett Syndrome Organization. She's the Director of Family Empowerment. And if there's one thing that we all believe in, it's family empowerment, so we can help make a difference for our daughters and all the people that we work with and that we touch in school systems, wherever we're at. Special thanks to all the doctors from Rush that spoke today. We appreciate all your hard work and dedication. One person I want to recognize also, and her name was mentioned before, is Marie Kroll. For 9 years, from 2006 to 2014, every spring and fall, she organized 17 natural history studies with Dr. Heydemann at Rush. And that's one of the reasons we have some tremendous doctors at Rush there, and we have a Rett Clinic there. So Marie, Dr. Heydemann, all of you, thank you for everything there. One of the things that we're proud of too is we started October's Rett Syndrome Awareness, and we believe that through more awareness comes more support, through more support comes more participation in our events and in our fundraising. A few other people I'd just like to mention that have always been supporters of Rett Illinois: Mike and Kay Borchard, Brian and Kent, Kathy Walsh, John McGovern and families, Tom and Nola Sluter, Adam Levy, Mick and Diane Ross, and our Cami Can parents, Bill and Jackie Barbaretts, who amaze us every year. We've got faith and hope that research will find treatments and a cure for Rett syndrome. Janelle and I have a quote about winning in our day-to-day living with challenges like Rett syndrome and COVID. Winning is never giving up. We may not win life's battles every day, but we don't give up on our daughters or ourselves. So thank you, Paige, for everything that you're doing, for everybody that joined us today. Back to you.
Thanks so much, Paul. My gosh, and congratulations on the success of RSAI, and we're so grateful for your partnership. And thank you for mentioning all of those names. So many have contributed to the success of RSAI, and we've got something going with state proclamations. It's loud and proud across the country now. Almost every state has signed on to declare October Rett Syndrome Awareness Month, and that creates a lot of awareness with our elected officials. So thank you for that and setting that example. Well, I know everybody has been waiting for, and I know we're over time, but I don't know about you. I'm not going anywhere these days. And I hope that you know that you're at home, you're on mute, you don't have webcams on, so feel free to move about your house and do some stuff while we go to Q&A. So what I'd like to do is invite Dr. Heydemann and Dr. Buhrfiend and Dr. Barry Kravis, as well as Shelby and Marie. I think we can go up to 6 webcams. Go ahead and turn your webcams on. We're going to take slides off, and we're going to go to audience QA. I think many of the questions that were pre-submitted have been answered by our presenters. But if you have additional questions, now is your time to write them into the question queue. We'll spend about 15-20 minutes going over the questions. If I start seeing a ton of people drop off, we'll close the town hall and take the questions offline and get answers out to you. If we see you staying on, we'll take all the questions to the very end. So turn your webcams off and let's go off slides.
Okay, can people hear me? It's Peter Heydemann.
Sure can.
Well, I'm going to read the first question that's on our list. Are there seizure-like movements that last over an hour that can be treated? Our doctor says they are not seizures, but just Rett. So Colleen, what do you think? Would you like to answer this?
Sure, yeah. So seizure-like movements and even Rett spells are very common in patients with Rett syndrome. Some of the movements that the girls may have would be like small little tremors or myoclonus, which are bigger jerky-like movements of the extremities or the entire body, stiffening, or even arching episodes. So those are the movements. They also may have spells that look like seizures but aren't seizures, which would include just staring off or freezing type spells. And with those, sometimes it's difficult to tell whether they're truly seizures or not, and we might go forward and get an EEG to help determine between this non-epileptic events as well as or versus epilepsy or seizures. They also have hyperventilate. They also hyperventilate and they breath hold. And during this period of time, they may also be seemingly unresponsive or a little bit just not as responsive during these periods of time. They can also have laughing and screaming episodes. So there are a lot of seizure-like movements and spells. It's going to be important to try to differentiate and choose exactly what those features are so that we can kind of characterize what the movements or the spells are, and then we can go forward once we know what they are and try to treat them. So some spells are short. To answer your question more specifically, some spells are short and some may last a long time. If they're lasting about an hour or so, they're less likely to be seizures. But either way, we just need to know the features and characteristics, and then we can go forward and try to treat that.
On the treatment front, the next question may be a play off of that same one. Are there any medications that can calm down the autonomic nervous system for non-epileptic events?
So sure, we feel that maybe anxiety plays a role in triggering some of these spells. So we try to, if there is concern for anxiety, we try to treat the anxiety with either serotonin reuptake inhibitors or other medications such as other anti-anxiety medications such as Buhrfiend. Sometimes we can use clonidine or 10x, sometimes can help dampen activity levels. So there are medications that we use to treat the spells. And if they're movements, because I think one of the questions talks about treating various movements. For myoclonus, oftentimes we go forward and we'll treat myoclonic jerks with either clonazepam, or sometimes we can use Keppra. If they're spastic and real tight, we oftentimes use baclofen, which is a muscle relaxant. That's the most common one that we use in kids. If it's severe spasticity, you can think about using a baclofen pump for severe spasticity. And if you're concerned about dystonia, sometimes it's hard to tell the difference between spasticity, rigidity, and dystonia. But if it's true dystonia, Artane, medications such as Artane may be helpful, as well as amantadine, and you can try even Cinemed. So there are medications that we can use to treat some of the abnormal movement, as well as the Rett spells, especially if they're associated with anxiety.
Okay, let's go to a research-related question at the moment. I think I'll give this to Liz if you want to try this, Liz. Will trofinetide or any drug reconnect nerve pathways and get rid of our girl's seizures and allow her to talk and use her hands?
Okay, well, that's a tall order, but I believe that the idea is that trofinetide would allow some reconnection of pathways. That's basically how the drug is supposed to work. It's supposed to foster those neural connections and help the neurons fan out and make more connections. And we don't know what would happen if you were on trofinetide for multiple years. We don't know if the effect of trofinetide would build over time because we're still fairly early and that we've only had short-term studies. But the idea is that, yes, it would, because it works on theoretically the Rett mechanism, it should work on many of the symptoms of Rett syndrome. So I think in the trials, we've seen some girls that were using their hands somewhat better and may have been more balanced and stuff when they were walking. We are still blinded, so we don't actually know which ones were on treatment when those things happened. But that would be the goal. But I wouldn't expect the girl to go from not using her hands at all to normal hand use. That, I think, is going to take multiple kinds of combinations of therapy and possibly an early start to treatment, although we don't totally know that either. But yes, I think we are looking for mild improvements in all those areas in early drug trials, and we're hoping to build on that to get more substantial improvements over time.
All right, I'll take this next question. Which I may get, maybe some people from Rett Syndrome of Illinois can help me on this one. Is there any monetary help out there for us to get our daughter equipment? Now, my answer will be there are a number of organizations out there that are tending to be small private things that do have used equipment and can loan it or give it. Lexi's Closet, the Kids Equipment Network, the ATI Foundation, Riddick's Ride, the Illinois Assistive Technology Program, and I understand that Shirley Ryan has a website for some of these kinds of things as well. Also, Division of Services for, the Division of Specialized Care for Children, DSCC in Illinois, if you qualify for that, can help buy equipment. And with that, I think I'll pass it over to anybody who has experience from the parent point of view.
You're right, Dr. Heydemann. DSCC is a great group. If your daughter or son have seizure activity, you can certainly apply there. It's not, everything isn't based on money made. So it's a great organization if you would like to call them. I also have a couple of families that, you know, do large fundraisers each year, and they accept applications to give you different pieces of equipment. And also this Rett family of ours here in Illinois, and again on the Facebook page, we have so much equipment that we donate to our schools and everyone else. If there's something you need, let one of us know. Chances are we have some really good equipment that our girls and boys have outgrown.
That's great to know, and we'll recommend that too. Thank you.
Thanks. If I can, and Dr. Heydemann, if I can just jump in on there, I would encourage families to not give up on that first denial from your insurance plan. Appeal. And I know that your Rett Clinic team will help you write the right letters to appeal and justify a lot of equipment for medical needs. And sometimes it just needs to get that right wording. So don't give up on that avenue. And also, if you have a health spending account through your employer and you reach the end of the year and you are lucky enough to have not needed it otherwise, a lot of those funds can go to buying some of these pieces of equipment as well and make a lovely holiday gift. So that's my addition. Go ahead.
Thank you. I guess I'll take the next one. If somebody else kicks in that has something to add to my answer here. This is about the benefits or current research regarding CBD, cannabidiol, and THC, tetrahydrocannabinol, for sleep, for seizures, for Rett episodes, and hand mouthing. Well, for all of that latter stuff, including seizures, milder seizures, CBD is being studied, as you know, from listening to what we've said about the cannabidiol trial. In addition, cannabidiol has been tested and proven to work for treating seizures. So that is that's the already known news. I don't think we know as much about THC. It's a more restricted drug, you know, cannabidiol as a purified drug without THC or with minimal THC is approved for use with not great restriction. The THC hasn't been well studied. Now, people have offered the idea that maybe THC or a little THC helps CBD in treatment of epilepsy, that it may be calmative and you know, theoretically might help Rett spells, we don't know, or Rett anxiety episodes. Certainly the combination of CBD and THC is used in a drug approved elsewhere. There's a drug called Sativex in England, Spain, and New Zealand, I understand, which I've never used, which is authorized for spasticity treatment in multiple sclerosis. So I'd leave it at that. The CBD is certainly in progress, and we should have some answers on that in a little while. The addition of THC, I think, is farther out on knowing what it's good for exactly. All right, and you know, and I guess I could add that again, the mice, which and mice have been known to lie about findings, but in mice, cannabidiol, which is another analog of this, has been shown to improve brain weight and Rett behaviors. So there is there's something to say about CBD and more fundamental change in mice. All right, let's go on here. Well, Colleen, I think you've already answered this one, how to treat dystonia better. You talked about the various medications, and I don't think we can do that well, any better than that. Liz, I don't know if you know this, is there a database to look up children's specific mutation and cross-reference with current research or clinical trials?
So there are databases that list all the Rett mutations or all the mutations that have ever been described. There's something called ClinVar, which is a national database of mutations and everything. So you could look up, has your particular child's mutation been seen before and how many times? But it doesn't, but so far there is not really a good correlation between mutation and response in clinical trials. And that's partly because we're so early in the clinical trials in Rett syndrome. If you look at the total number of people that have been in a clinical trial of one of these drugs that's moving, that's working supposedly on the disease mechanism, it's only a couple hundred. So we wouldn't, because many of the mutations are different, there's some common mutations that reoccur. And so you've got some clusters of mutations, but a lot of them are different. So you wouldn't have enough patients with any one given mutation to make a correlation right now about who responds to what in terms of a clinical trial. That's certainly a goal for the future, and it's something that will be important to track in all of the kinds of Rett databases that we're collecting as a part of trials and as a part of the natural history study to understand who responds to what and whether mutation has an impact on that. But we don't have it yet.
Okay, Colleen, are there any trials that are available for anxiety and tics? Or maybe
I think,
go ahead.
yeah, go ahead. Or Liz you might answer that because she did discuss that a bit. Go ahead, Liz.
Yeah, I think the CBD trial, the Epidiolex in Rett trial is targeted to anxiety. That's the idea, that it might help with anxiety. Tics in particular, I don't think anything is particularly targeted to tics, and it might be hard to discern what's a tic and what's a different kind of movement in someone with Rett syndrome. But in general, the CBD type agents, as Peter mentioned, have been approved for certain kinds of spasticity and movement disorders in other countries. And so in the CBD trial, they'll be looking closely at things like epilepsy, as well as anxiety, as well as other behaviors, as well as other kinds of movement problems. I think that would be the main one specifically directed at that. I mean, anxiety could be a secondary improvement. It could be part of what improves in any of these trials.
Right. Yes, thank you. Is there a chance for an 18-year-old Rett patient to walk and have therapy? I think of of walking as having a certain progression, that a person has to be able to balance their body first in sitting position. They have to have reciprocal leg movements, and they have to be able to balance the body in full upright posture. So those are the steps needed for walking. If you don't have those preliminaries, you're not ready to get to the walking stage. But if you do have those preliminaries and you're in the teenage age group, while it's unlikely, there are case reports of people learning to walk with Rett syndrome in that age group. And I would say what makes you willing to try that, or in my mind, what would make one willing to put the effort into making that push forward, is how close you are with the preliminary steps, that you're there in balance and in reciprocal gait. Any other thoughts to add to that? All right.
Makes sense.
Is our clinic taking boys with Rett? Yes, we do care for several boys with either Rett syndrome or MECP2 mutations, as well as MECP2 duplication syndrome.
Yeah, and I have several boys with CDKL5 also, so we see the full spectrum.
Now, Liz, here's a question that I don't know if you can stick your neck out on or not. Which research study is most promising?
You know, I would say that, so trofinetide has the most data, I would say. They've advanced the farthest, and they've managed to have 2 successful trials in people, which I think makes that a very promising drug. It's a drug that works on neural mechanisms. It doesn't completely replace the gene, so it's a drug that it looks like can be helpful for Rett, but may not cure Rett, for instance. So, I mean, to have a full cure, again, we might need combination things, but the genetic strategies are certainly an option that might provide a more complete reversal of the condition, but on the other hand, they're not quite as far along. So I think really we want to look at what we want to take what we have now and advance that, and then try to build on that and kind of get better things in the future. I mean, I'm very hopeful about the gene therapy. I think it's a great advance, but I think there are going to be, we have a lot of hurdles to get over while we're learning how to best use it. And I think the one that has the most data right now and you know, has the most potential to move forward as a treatment is Trophenite. But again, even that trial has some hurdles.
Okay, thank you. My daughter, I'll answer this one if I can. My daughter, age 32, is doing very well using a THC transdermal patch to help with seizure control. She has been using this for almost 3 years and has weaned off about a third of her seizure medications. And we are thankful to our neuro team at Rush for support. I appreciate the positive comments, and I don't know where your THC patch is coming from. We are not prescribing the THC patch, but certainly we're tolerant of people who use things that are legal. And I'm glad it's worked for you. And certainly people have talked about the balance of THC maybe being important, but we're not there yet in a real medical sense. But we'll look for this area in the future. What are the options for older healthy girls in medication trials? I can say that Anavex was focused on this in their last trial that just ended, but Liz, do you have any other comments?
I think right now the other ones do not have older adults. I mean, they do go into the adult range, but mostly younger adults. I think adults in general in clinical trials, there are opportunities for adults very early in development because often we have to do a safety trial in adults first, which is what Anavex just did. And then after, as things go forward, after the drug is getting further along and we're trying to understand all the populations that the drug might work, and then there tend to be more opportunities toward the end of development. So right now, I would say I don't think there's anything open, but there will be opportunities. I mean, there will be new things in the future and opportunities, particularly early on when drugs are first being explored.
Okay, thank you. Colleen, a common problem in Rett syndrome is abdominal bloating. The parent writes, what can I do about the amount of air in my daughter's abdomen?
I should get my cap.
So yes, I mean, it's a very common problem you're swallowing. The term for that is aerophagia. Also, in addition to that, they have slow gut motility. So you may try, for example, using simethicone, which is helpful for gas, as well as massaging the abdomen. You, of course, want to treat constipation to kind of move things forward. And if there's a G-tube, you can try to vent the air. You can vent the G-tube to try to get some of the gas out of the G-tube. Now, if these measures are not effective, then it's best to definitely see a GI specialist where they can look for other potential causes for bloating, such as lactase deficiency, and sucrose, where you may need to alter the diet. So again, if these initial measures aren't helpful, then it's time to see a further evaluation.
I can hear. Or, I mean, your phone's not hooked up there, so.
But you could dial it through your
anybody who's talking in their own rooms. Sounds like Paul. Turn off your mic if you want to have a background conversation. Thanks. There's another question here about spinal fusion. My 41-year-old daughter had a spinal fusion at age 14. Should I have any concerns as she ages? Well, this is out of my bailiwick, and I consulted one of the spinal surgeons who works with us, Dr. Margetko, who answered as follows. This was done 27 years ago, and I'm adding, I think operative mechanisms have changed. So she was operated in the early 1990s. So probably some different mechanisms were used then. What level of spinal fusion was done is not stated. He says that in ambulatory patients, he tries to avoid fusion all the way down to the pelvis, so that he prefers to stop around the third lumbar vertebra and not go down to the pelvis, and go as high as the second thoracic vertebra, or not all the way to the top, not to the cervical spine, is preferred when he can do it that way. But if the curve extends to the pelvis, then fusion should extend to the pelvis. He says that these fusions from long ago are likely to be solid and should not cause any problems for the remainder of one's life. However, issues can occur at the proximal, meaning the top, or distal, meaning the bottom ends of the surgical site. There can be degeneration with kyphosis, and there can be spinal stenosis at those levels. Cervical spine degeneration can occur as well. Focus on bone health, vitamin D, and calcium, and he recommends routine orthopedic follow-up at 3 to 5 year intervals for the older patients. So there you go with a detailed answer from a spine expert. Let's see, here's one for Liz. You can also take a stab at this. How far away are we from a real cure?
Yeah. Okay, well, we thought we had the real cure in Fragile X in 2002, and we're still working on it. So I think, we have a real challenge. We have a brain that has developed wrong, and we are trying to get it to reverse itself and make itself right. It might theoretically be easier to start at birth or even before birth and get the brain to wire right from the beginning. And Rett patients have this period of more normal development. So maybe if we have that window of treatment before they actually regress, and if we had, say, newborn screening or something where we could find the patient, we could, allow for a pretty normal development if we had the right agents, like a complete genetic correction or a combination of things. I think in terms of a cure for girls that have already gone through a regression, we are probably looking at a cocktail of things, and we are looking at long term. And the way this works is kind of like cancer, like back in the 1950s when you got cancer and you just died. And then they found steroids and they found chemotherapy, and they built and added one thing on another. And now a lot of cancer patients survive because of all the work that's been done. But it's not a thing where there's a single bang and now it's a cure. It's a thing where we develop Trophenite, and then 5 years later we get something slightly better, and then we get something slightly better, and then we build to different levels on each different kind of treatment, and we add the genetic treatments. And I don't think it's around the corner, but I think what we hope to see is continued improvement in what we can offer patients with Rett syndrome, so that there's kind of a gradual upping of function until we get close to that elusive sort of cure.
Okay, thanks. So not tomorrow. How can you, and I think this might be the last question, so if there are other ones that have come in a minute, Paige, you can let us know. How can you help define the need for continued therapies in the school environment as children get older? I think this is a tough question. It's a tough question based on perceived needs and based on, I hate to say it, the generosity of the school system to perform vigorous therapies as kids get older. Because some school systems tend to get more restrictive as the kids get older. I think it's a very individualized question as well, depending on what abilities the child is on the cusp of. If you find a child who seems to be on the cusp of certain abilities, I think it's worth a lot to give them that push and to work very hard to try to get them over the cusp to gain that ability. And this applies not only to the school therapies, but how you engage outside therapies and push for insurance support of some therapies. The roles of the parent, of the school, and of the private therapies, they're all sort of working together. They're not always well coordinated, and I think it's unfortunately the job of the parent to try to help get these things coordinated, to get people working in the same direction. When insurance companies don't want to pay for more than a few therapies a year, then you have to decide how to make those therapies more valuable, which means to me that the parent becomes the more direct therapist, or somebody in the home environment, or an aide, perhaps, if they're willing. And the physical therapist or speech therapist or whoever it is becomes more of a consultant who every 2 or 3 months or maybe monthly helps to supervise what's been going on and look at the progress and tell you next steps to work on. So I think it's a group practice on that one. And Marie, you look like you might have some thoughts, do you?
I think it really is so individual. Like you say, it's so specific to if you're working with school-age children, it's so specific to the district and the classroom. We are over the hurdle now where our individuals have to be making progress. They do allow for maintenance now, which is just an incredible advance in terms of wording and getting teams on board to help you. I have a 22-year-old who I am still able to get private physical therapy and occupational therapy for. OT is off right now because of the virtual, but we are doing virtual PT. And so I think right now it can be a little bit easier to continue, but you are right. We almost have these supervisors looking at what we're doing in the home and making sure that we're going in the right direction.
Okay, and finally, I think, whether to, how to push for therapies in the COVID-19 era. Colleen, is there anything additional to say?
I think I discussed this earlier in my slide presentation, but just again, if there's a choice between video and going in person with regards to therapies, it's again individual, what the patient is able to do at home. And if they're making progress, it's fine to do it at home. But if they're losing ground and becoming either more tight or less mobile or less communicative, then it might be better to try to get those therapies in person. So again, it's very individual.
Yeah, and certainly try to stay active even in the limited home environment. Paige, anything else come in?
Yes, we do have some questions that came in. Just following on communication, therapy, time of COVID, older people in school. I want to acknowledge that we are on the 30-year anniversary of the passage of the ADA, the Americans with Disability Act. And thanks to the ADA and IDEA, we have a lot of laws and protections on our side to advocate for access to equipment, access to the community, access to therapy. And use the advocates in your community so that you don't have to become a lawyer yourself, but those rights are secured, and sometimes it just takes a lot of back and forth. Resources are limited, especially in the time of COVID. Everything is stressed, but nobody cares about your child more than you do, but there are a lot of experts who will get behind you. So don't give up. And Rett syndrome, although it's not degenerative, it is progressive. Maintenance of skills is progress. So we certainly, especially in our older kids, we don't want to let things like contractures or lack of communication cause depression and lead to isolation. So the communication guidelines are available to you as evidence-based that communication can begin at any age. Don't let that get in your way. And I speak to the newly diagnosed families as well, who certainly are not as familiar with this world of special needs. There are a lot of resources available to you, and get them early, get them started, get them secured, get them integrated into your life, and you are going to have so much success. There's just so many beautiful things that your children will be able to learn and do, but you have to be their advocate. So get off my soapbox.
A wonderful statement. Thank you for whoever wrote it.
Oh, I just spewed that one out. Okay, so let's get back to the questions in the queue. But that's my soapbox. Okay, Question from a family who used to be part of the natural history study, thought it was over. Can they participate again now that funding is continued?
Well, the answer is yes. And if you saw the phone number on there, I can repeat it for Jeremiah at our place, who's the coordinator for that study. His phone number is 312-942-0079. And his email would be Jeremiah, Jeremiah _Furman, FURMAN, @rush.edu.
Fantastic, thank you. And everyone will get a copy of the recording to this presentation, so you'll be able to fast forward back to that slide where Dr. Heydemann gave everyone's contact information. So please continue to participate in the natural history study. Dr. Barry Kravis said that is one thing that's given us a big leg up in the Rett syndrome field of research, is having all of this large metadata about all kinds of individuals with Rett syndrome. Okay, and Dr. Barry Kravis, we have a question for you. Can you talk about whether specific mutations are more conducive to the splicing gene therapy?
Yeah, so those mutations are very individualized. They generally say in the report that it's a splice site mutation, and some, not all, some splice site mutations can be modulated by these antisense oligonucleotides. And in fact, for certain super rare disorders, there are labs that are designing kind of a designer ASO for people who have one of these intronic or splice mutations to cause the gene to splice correctly. And there are some examples of those being employed in a single individual in something, in basically a compassionate use or expanded access program to treat that one individual. But this is expensive, and it's directed at one person basically, because all of those, there probably are some repetitive splice site mutations in Rett, but probably a lot of them are different. And so it's kind of a therapy designed for a single person, which doesn't make it something that commercial development is really, that commercial development is really going to support. It's something that has been done on a one-off basis, working with a research lab that creates these ASOs. So there's work in that area. There's talk about, having in the future labs that can create ASOs for people with any disease that have the sort of mutation that's amenable to them, but that's not being done yet. That's kind of a future hope. And that would, of course, not just be for Rett, it would be across all diseases where there are these splicing kinds of mutations.
Okay, thank you very much. I feel like, we're in harvest time, and we're looking into the bowl of a cornucopia of a lot of different things. So I'm going to go from splicing over to a waiver question. Marie, maybe you can answer this because I think Shelby had to depart. But a family asked, what is the PUNS list? They've never heard of that waiver.
Okay, in Illinois, it is important to get hooked up with your local DHS and get on what's called a PUNS list. It's a priority of funding. By law, they have been directed to give a family an estimate of when they may get in the fold of getting some funded, either for funding for either home-based services or some vocational services. It's particularly important as you're getting older and not going to be in the school system anymore, but it can be very useful for young families to get some respite or some equipment in your home. But anyhow, so that, and Shelby or I, you can either contact one of us or go through our Facebook page and ask if we can help get you connected to your county service organization and get you on that PUNS list. It's your responsibility to update your child's name and information on that list annually. Right now, they're pulling on or they have for many years, a lottery system. It's not necessarily based on need, although if you get to the point where you have extreme needs, you can get pulled more quickly, but there's a matrix, a rubric that they follow. So please make sure you get on that priority list in the state of Illinois. Not only does it help them plan now, it helps them plan for the future when that bus stop's coming, and it surprisingly comes very quickly. So, again, follow up with us on that, on our local group, and we'll make sure that we get more information to you.
Thank you very much, Marie. Gosh, no one of us is as smart as all of us. So thank you for everyone contributing. Dr. Heydemann, we had one family who I think is in a very unique situation, not common with Rett syndrome, but is asked repeatedly about the ammonia level issues. And I'm not sure if that's something that you want to take here in the forum.
I will take it just for a moment.
Okay, thank you.
You know, I was doing my residency in neurology in between 1979 and 1981, I guess, or 78 and 81, long time ago. And I did a conference on hyperammonia disorders. So I looked this stuff up, and of course, Rett syndrome at that time was listed among the hyperammonia syndromes. Well, what happened was, it turns out not to be true, and ammonia has no relevance in Rett syndrome. But what happens with ammonia samples is it's very hard to get a true reading. If the sample isn't the right temperature, if the sample takes too long to get to the lab, and perhaps other reasons I'm not aware of in the lab, it's easy to get a falsely high ammonia. Now, in the case of the early studies that suggested this, the ammonia samples were shipped from, I forget where I think Austria, where Dr. Rett was, to France, where they did the studies. And of course, ammonia samples can't be shipped. The storage just doesn't work to measure ammonia. So it's a false thing. Ammonia levels have nothing to do with Rett syndrome.
Okay, and this might be a very unique situation where this was something not related to Rett syndrome, but that happened with their child and led to some pretty severe outcomes. So if it's okay, I might, and this parent gave some more details in the question queue. I've assigned them to you. I think we might want to, based on your answer, that this is not something generalized to Rett syndrome. If we can connect the two of you offline, I would really appreciate it.
Okay.
All right. Okay. All right. Well, everybody, wow, we have had, this was like speed dating with Rett syndrome. We have covered everything from newly diagnosed to when the bus doesn't come, to research, from Fragile X to MECP2, duplication syndrome to CDKL5, and back to Rett syndrome. And you all have done an extraordinary job. I couldn't be more proud of the panel that came together today. All of the families that have contributed to the success of the research studies, who are waking up every day after not sleeping the night before because of your dear loved ones, keeping you up partying all night, and still rise to the occasion. You care for them, you love them. There is no one way to live this life, but there are a lot of ways to go from grief to growth by working together. We get a lot of hope from those of you working on Rett syndrome because you've chosen the path. We as parents had it delivered to our doorstep, and we bow down in humbleness and gratitude to those of you who have chosen to support us. So thank you very much, especially during this challenging summer, for not giving up on us. It has really really meant a lot and has kept us going. I'm glad that we're working towards a new normal and progress is happening. Please, I'm going to let everyone go now. Get back to your weekends. Know that this will not be the last time we're together. As soon as things come together, we will come back to Chicago and be as one in person, which is the best place to be. Until then, I'm so glad we have had this technology to bring us together online. So let me ask our panel, do you have any closing thoughts, words of hope or motivation to share with our families before we close up for the day?
No, keep the girls active, hard as it is.
Keep on working with us. We need to power forward.
Absolutely. All right. Thanks, everyone. You all, you know how to reach me. and I'm here for you each and every day, as is this team. Thank you so much. Enjoy your weekend, and we'll be together again soon.
Thank you, everyone.
Thanks, everybody.
Everyone.
Bye.
Bye.